This is a list of the common red eyes that you might see coming in to a primary care clinic that a patient's be looking, and we're going to be touching on all of these today. We're also going to be dealing with these ones here, which are more serious, and the ones you really want to be concerned about, the vision-threatening red eyes, the ones you definitely don't want to miss. So if you're differentiating, you want to try to make it easy and look for the red flags that really pique your interest and say, hey, I got to pay attention to this situation. So 4 red flags if someone comes in with a red eye you want to really take note of. One is reduced visual acuity. Another one is pain. Another one is a difference in pupil size. I'll talk a little bit about this one here. Basically, if you have anisocoria of 1 millimeter or more, that can definitely be a sign of a serious eye problem and something you should be aware of. Now, take that with a grain of salt. That's a textbook answer, because in real life, a lot of times the cornea might be so cloudy or the patient might not be cooperative enough to open their eye that you may not get a good look at the pupils anyways. Selena, do you have any notes on that?
20% of people, or 1 in 5 people, naturally have anisocoria, so they will have a difference in pupil size. And also, most people with 80s tonic pupil do not know they have it as well.
Excellent. And another red flag is if you have a red eye, particular one with reduced vision, pain, and weird pupils, and they're a contact lens wearer, you definitely need to pay close attention. All right, visual acuity time. So we've got this chart here. If you know who invented this chart, feel free to put it in the chat if you want. On that note, if you have questions along the way, feel free to write them in the chat. We're happy to answer questions. Answering questions is always easier than lecturing. So visual acuity, if the visual acuity that you're measuring is reduced, and I'm going to give you an arbitrary number. If it's reduced to 20/40 or worse, you need to be concerned. Watch for that. One thing that you're likely going to have is a paper acuity chart, and what you want to do is take mind of where your tape is on the floor, of how far that is, because there's different Snellen acuity charts. Some are designed for 20 feet, some are designed for 10 feet, and you want to make sure that your distance that you're measuring for is appropriate for that. It's pretty common that it might not be in the right spot. So when you're taking visual acuity, you want to measure their best corrected visual acuity. And now, obviously, the best way to do that is with their best pair of glasses that they're wearing. So if they have their glasses with them, have them put them on, take their visual acuity with that. But if they don't have their glasses or they're not up to date, then what do? You can use a pinhole. So using a pinhole, looking through that, it can increase their depth of focus and should improve their visual acuity. Now, personally, whenever I've done visual pinhole or someone's done it on me, I feel like my vision's worse, or I never get great visual acuity. So I don't love it. I just do a refraction. Selena, what's your experience?
I use it a lot because it tells me really quick and immediate what their best vision is with glasses on. And if you don't have one, they're super cheap to buy. But if you just take a pin and actually get a piece of thick paper and put a hole in it, and hold it in front of the patient, it's a quick way of finding out what their best vision is.
So it eliminates the refractive component for you. All right, let's talk a little bit about pain and what pain actually is, because everyone's definition of pain is a little bit different. If there are different conditions, and different conditions, you can differentiate them a little bit based on what they're feeling. And if you just ask the patient if their eye is painful, sometimes they might really be painful, but it may not be. It might be just discomfort. So you need to kind of probe, not literally, but figuratively probe into what their symptoms really are. Is it pain, or is it irritation? Is it a foreign body sensation? Is it burning? Is it aching? Is it a boring, pain? Those type of things, because you want to find out how intense that is. At the bottom here, I've put a note of photophobia, and photophobia is a great question to ask. Are they sensitive to light? Because photophobia can be one of the main reasons why they're having so much discomfort and so much pain. The physiology behind that, there's 2 things that will cause you to be photophobic. One is if your cornea is swollen. So if this cornea is swollen, it's going to scatter light more, and that's going to make you very sensitive to light. And the other thing that will make you more sensitive to light is any inflammation in the ciliary body. And if you have inflammation in the ciliary body, every time your eye tries to focus, that's going to be super uncomfortable. And also when you go from light to dark, that's going to be super uncomfortable. And that's one of the reasons why you'll see us prescribing cycloplegics to reduce that focusing of the ciliary body. All right. So what do you do? You got this patient. You're identifying that they've got a lot of pain. He's not moving his hand off his eye, and you're not getting a visual acuity. You can't even get a look. What do? So topical anesthesia could be your best friend. I love using this because it can allow you put a drop in. You can get a visual acuity. You can talk to the patient. You can examine the eye. So you're going to put that in. One thing you want to be aware of, you've got about 10 minutes to do your work, and then it's going to be uncomfortable. I always tell the patient, this is going to be enough for you to get out of my office and be happy, but on your way home, this is going to start to be uncomfortable again. Any comments you have, Selena?
I'm opposite of you. I hold off as long as possible because I actually want to see how much symptoms and pain they have, because this totally eliminates any pain and symptoms. Also, you have to keep that bottle in your hand and put it in your pocket. If they see it in a drawer or at a counter, they probably are going to swipe it. It makes a super mushy cornea. And so I really scare them about touching their face or eyes while this is in effect, because they can cause a huge corneal abrasion.
Yeah, that's a good point. I mean, I do, I guess I don't jump in right away to put this in. I wait a little bit until I absolutely have to put it in, because it's good to see how much you can examine without it.
And I agree, you want them out before it wears off.
Yeah, and the patients you will have patients ask you to prescribe it, but do not prescribe it, because like Selena said, this can impair the integrity of the cornea. So the fourth red flag, contact lenses. If someone has a red eye, comes in with a red eye, particularly a hot, angry red or painful red eye, if they're a contact lens wearer, you want to be very, very careful, because there's some really nasty organisms, Pseudomonas, acanthamoeba, fungus, that are related to contact lenses. So you want to assume that's the problem until proven otherwise. So you want to ask questions like, how often do you wear your contact lenses? When was the last time you wore them? What type of lenses do you wear? And how old is your current pair? How old is your current case? Do you sleep in your contact lenses? What solution do you use? Things like that. When's the last time you took them out? Those are all great questions to find out. You're trying to figure out, is this a contact lens problem or not, and how much it is. Any comments you have about contacts?
I would really word my questions carefully, because I would not ask, do you wear contacts? I would ask specifically, when were they in last? Because they may think of themselves as a glasses wearer, but they wore the contacts 3 days ago. And then not ask if you sleep in lenses, but when's the last time you accidentally fell asleep? We know from a bunch of lawsuits last March in the U.S., Pseudomonas was found in some artificial tears, and a number of people died, and there was quite a few enucleations. So that Pseudomonas thing is a real fear.
It's a real thing. So for those of you that are not contact lens wearers or aren't familiar with them, this is your contact lens crash course. Here's your crash course on contact lenses. So there's different materials of contact lenses. The most prevalent and most common contact lens is a soft contact lens. Probably 99% of the world wears a soft contact lens. These are very flexible lenses. There's also rigid gas permeable, otherwise known as hard contact lenses, sometimes can be referred to as a special type of ortho-K. And so these are a hard piece of plastic. They're not flexible, they're not bendable, and they sit right on the cornea rather than draping over the entire cornea. And so there's less people that are using them, but they are out there. You'll see them more and more in kids, or they might tell you they're wearing something called ortho-K. Ortho-K is a special type of gas-permeable contact lens that kids will sleep in, and I guess adults could do it as well. They can sleep in the lens overnight, and it changes the shape of their cornea, and in the morning they take it out, and their cornea is a different shape. So this is kind of like orthodontics there to dentistry. This is orthodontics for the eyes. So it's a temporary change of the shape of the cornea. So it's pretty cool. Also, there's scleral lenses, which is another hard contact lens, but it's a very large contact lens that doesn't sit on the cornea, but it actually rests on the sclera or on the conjunctiva, and we use that a lot for conditions like keratoconus, or people that have warped or distorted or surgically damaged corneas, or it can also be used for treating dry eye. Replacement, if we're talking about soft contact lenses, this is all about soft contact lenses and the replacement. There's going to be basically three modalities of replacement. There's daily disposable, where you wear the lens, put it in the morning, wear it all day long. At the end of the day, you take it out, toss it away. Next day, you put in a brand new clean lens. That's a daily disposable. That's becoming more and more the mainstay of contact lens wear. It's the best, most convenient, healthiest, everything the best about it, except it's more expensive. That's the only thing downside of it. There's also monthly and 2-week lenses where monthly you put in the lens, you wear it during the day. At the end of the day, you take it out, but then you have to clean it. You have to go through some type of cleaning regime. You have to put it in a case with solution to disinfect that lens overnight. Then you put that lens in the morning, and at the end of the month or 2 weeks, you toss that lens out and start on a new lens. All of these lenses you're not sleeping in, you're just wearing during the day. There's different types of solutions out there. There's a bunch of multi-purpose solutions which you can rinse a lens, disinfect the lens in, put it in your eye, and no issues with it, and clean and rub the lens with. But there's also some hydrogen peroxide solutions which need to be disinfected before they're can put the lenses back in. Cases are also something to be aware of. You should be replacing cases on a regular basis. Less than 3 months, changing your case. Yeah, you can get a biofilm, and it's a great incubator for growing stuff. Any more comments on
the reason why, like, it doesn't matter how many times you wore the lens. It's 2 weeks after you open the lens, or 1 month after you open the lens. Our tears have proteins like lysozyme in them, and the lenses are 30 to 70% water content. So whatever was in their tear the first time they wore it is embedded in the lens. And with that, whether it's in the case or wearing them, the proteins denature, and denatured proteins elicit immune responses.
Yeah, and it's a good point that even with wearing a lens one time, you can get deposits that build up on it.
So there's a question about, can Ortho-K treat astigmatism?
To a certain extent, it can. Yeah, it can treat
Corneal astigmatism.
Yeah, corneal astigmatism. It can treat it up to a certain extent. It does have some power ranges, so in the really high powers, it's a little bit trickier. And if you have too much astigmatism, it can be a little bit trickier. But I think it's, if you have less than 2 diopters of astigmatism, I think you can do that. All right, so other questions that you might want to ask in your case history is about the red eye, is the duration and the recurrence of it. So basically, if this is an acute red eye, less than a week, you're thinking infectious, foreign body, trauma, something like that nature. If it's more chronic, you're looking at other conditions, dry eye, iritis, inflammation. You can have STIs that are going on as well. And then recurrence, you also want to think about, asking the patient, has this happened before? And sometimes they will say, hey, this has happened like 3 months ago. I just actually had a guy in this morning with a red eye, and he said, oh yeah, this happened a month ago, and we dealt with it. That can help differentiate what your issue might be. So other questions that are fantastic to ask are, I'm going to do this on my screen, are what they've tried and what's worked and what hasn't worked. And this can also help you tease out what the problem might be. So have they tried an antibiotic? Have they tried over-counters or prescription drops, and how long did they use it? Because if this is a bacterial infection of some sort, most of the antibiotics we have for this, if it's a good one, they're going to work pretty well. And so if they haven't been effective, then it takes you down a different road. You're looking at things that might mask symptoms. So if they're using a topical steroid or some type of vasoconstrictor, those can cover up symptoms and mislead you into this being less of a problem than it might actually be. Topical glaucoma drops, I put that down there, particularly the prostaglandins. These will cause your eyes to be red. So they will they will dilate the blood vessels of the conjunctiva. So if you have a glaucoma patient that's using glaucoma drops and their eyes are red, very well just could be their glaucoma drops.
Also, every eyelash serum that you buy at the drugstore will have some prostaglandins in it, and Lumify, which has a lot of commercials right now, also is a prostaglandin. These people don't realize that it does age the eye quite a bit, but that's down the road.
Fair enough. And then you want to be aware of something called medicamentoso, and this is not a breath mint. This is the condition when someone's basically, the problem is basically the active ingredients in the drops or the preservative in the drops are causing irritation to the eye. So sometimes if someone has a chronic eye problem, they come in with a couple of bags of drops. I'm on all these, and it's actually the drops. The problem might actually have been solved long ago, but actually the drops are causing the problem. So a lot of times in those cases, the first thing I'm doing is say, stop all the drops you do using. Let's see what happens, see what this looks like in a week, and see if it goes away. And a lot of times it seems like it solves the problem. All right, so discharge, the last symptom that you might have, is it mucus or is it watery, weepy? These can give you clues on this. You have any opinions on discharge?
Well, if it's bacterial, you're going to think purulent, and you're going to think pus. Bacteria is super rare, so it's a green pus, whereas the other stuff is kind of more mucousy and yellow.
Fair enough. Okay, so thinking about laterality, so is this a unilateral condition, red eye, or is it a bilateral red eye? And that's going to help differentiate things as well. But one thing that's going to be really helpful is taking a close look of where the redness is location and how it's presented. Because if you have a diffuse in the top left, we have a diffuse red eye where it's increased in redness towards the fornix. That can give you a different clue than one that's a sectoral there or hemorrhagic, or ones that on this slide they show what we call ciliary flush. So you'll see on the two sections on the right-hand side, right around the limbus, right beside the iris, you're going to see it's kind of like a little bit more red, and that's called ciliary flush or limbal injection, and that's a sign that there's probably some type of inflammation going on inside the anterior chamber or something going on the cornea, so it can help you lead down. That's kind of pretty common in iritis. So let's jump into the serious stuff that you're worried about. So infectious keratitis, so an infection of the cornea, is otherwise known as some type of corneal ulcer. So this patient's coming in, they're going to have a very diffuse red eye like this. They're going to have moderate to severe pain. Their eye's going to be very photophobic because of the swelling in the cornea. They're going to have decreased vision, particularly if the defect's right in their line of sight, and they're likely going to have some type of discharge. So the critical findings, you're going to see some focal white corneal opacity that's going to stain with fluorescein. So let's talk a little bit about the physiology of what's going on here. The fluorescein staining, when you put fluorescein in the eye, what that does, it highlights missing epithelial cells on the cornea, and it highlights damaged or irritated epithelial cells on the cornea. So that tells you that something's going on the epithelial layer. When you see that focal white opacity, what that is, that's in the stroma. That's underneath the epithelium, and those are white blood cells in inflammatory response in that area to this serious infection. The eye's trying to fight this off. So when you see this on the eye, and you don't need much magnification to see this, and there are contact lens wearers, you want to be very, very careful. So let's talk a little bit about putting fluorescein in. So if you have a fluorescein strip, the proper way is you take your strip out, you take a little bit of saline solution, a few drops of that on the fluorescein strip, and what you want to do is you want to pull down on the right, you pull down the lower lid, and then you can just dab that fluorescein strip on the palpebral conjunctiva of the lower lid. You don't put it right on the bulb of the eye, either superior or inferior. The reason why you don't want to put it there is because when you touch the fluorescein strip, whatever you touch the fluorescein strip to, it's going to actually irritate that tissue a little bit, and you're going to get extra staining right in that spot. So if you're putting it on the bulbar conjunctiva, you might be covering up a problem that you wanted to see. Maybe they have a conjunctival abrasion or some irritation on the conjunctiva that you wanted to see. Also, if they flinch, you have more of a risk of kind of brushing it onto the cornea, and it's also a little bit more comfortable when you put it on the lower lid And you can do that without any anesthetic. You do not need to use anesthetic to put this in.
I also tell my patients if they remember their anatomy, they might see fluorescent yellow on their Kleenex because it colors the tears yellow as well, and the tears drain into the nose, so they don't need to call you.
That is an excellent point. I often forget to mention that.
Just
So,
to prevent phone
so when you see these central, really nasty corneal ulcers, then you're thinking of etiology. You're thinking the worst things that you're thinking of are Pseudomonas, Acanthamoeba, fungus. These are really serious problems. These you want out of your office as soon as possible and get them treated by ophthalmology because these are vision threatening. They can have loss of vision, loss of eye within a short period of time. So the treatment, because there's a high risk in these really hot eyes, you want to be calling ophthalmology. They're likely going to be putting them on fortified antibiotics. So anything that's in the central line of sight, you want to get rid of. You obviously don't want to be the last person to see this patient. Now, on that note, there are other conditions that kind of look similar to an infectious keratitis. So on the right-hand side, the photo we've just been looking at is an infectious keratitis, central corneal ulcer. On the left side is an inflammatory response to the cornea in the peripheral part of the cornea. And this is called a sterile infiltrate or a sterile corneal ulcer. But basically, it still has that major inflammatory response in the stroma. But oftentimes when you put staining in, it may not stain over this area. It still might. But because it's out in the periphery, and you'll notice on the conjunctiva, it's not nearly as red. This patient is not nearly going to be as uncomfortable. This is a lot different and a lot more manageable. So here's a little chart, tell you a little bit of difference. So the sterile infiltrates, they're going to be smaller than the infectious ones. They're going to be more peripheral. They're not going to be in the central cornea. They're going to be less epithelial, so less staining than you might have, but you'll still have that white inflammatory response. You're going to have less discharge. You're going to be less pain, less photophobia. The patient's going to be in less discomfort than in the infectious keratitis. And there's not, if you have a slit lamp and you can look, there's not going to be an anterior chamber reaction, and the lids aren't going to probably be involved, but where the lids are going to probably be really swollen in the infectious situations. So, any comments on that? Okay. So let's talk about other keratitises or inflammations or infections of the cornea. So another one that you might come across is a herpes simplex or a herpetic lesion of the cornea. And this patient's also going to come in with a diffuse red eye. They're going to have moderate to severe pain. They're going to have sensitivity to light, all because the cornea is inflamed. They're going to have reduced vision, probably a really watery eye, not so mucousy. And now, if we talk a little bit about the pain, some of these patients can be in a lot of pain, but some of them actually may not be, because there can be an anesthetic effect of a herpetic lesion. And there is actually a test that you can do if you're suspicious that it might be a herpetic lesion. You see a lesion, you can do a cotton wisp test. You take a cotton swab and you kind of make it really fine, and then you just kind of brush it on the surface of the cornea of that one eye and see how, this is without anesthetic, and see how much the patient notices that, and then do it on the other eye and see what their comparative response is. But be careful, don't use the same cotton swab, because if it is herpetic, you don't want to spread it. It's a test. I think I've done it once in my life, so I don't know if you've ever done it. I don't rely on that. But the classic appearance is this dendritic corneal lesion, and this is oftentimes when the optometrists and ophthalmologists were getting out our cell phones because it looks really pretty. I don't know if the patients are often a little annoyed with us, but these they look pretty fancy. But it also can be a great masquerader. So this is actually a patient that I had, and these are both herpetic corneal lesions where I got out my cell phone and took a photo. So you'll see on the left-hand one, there is the start of a dendritic lesion there, but you'll see on the right-hand side, that is also a herpetic lesion. You can maybe get hints that there's a dendrite there, but not really. That could just be an abrasion or a scratch. So if you have a situation where someone has a lesion that looks kind of weird, but they have no history of having any trauma, then think in your mind, could this possibly be a herpetic lesion? So what are you going to do if it is? If you see this, what do you want to do? No steroids. Steroids are this is the number one reason why steroids are contraindicated in most epithelial defects, is because you're worried that it might possibly be a herpetic lesion, and you can make it much, much worse and make things go down really, really fast. Yeah. So the treatment for this is oral antivirals, and they work fantastic to resolve and treat these conditions, as long as you don't put a steroid on it. So let's talk about topical steroid use and the vision it has, the risk. So why do you need to be careful about using topical steroids in the eyes? Number one, it can accelerate any viral keratitis, which can progress to vision loss very, very quickly. It can increase the pressure in the eye and cause the risk for glaucoma vision loss. It can mask symptoms, so if they have some type of situation, it's going to cover it up. Now, oftentimes, if we know it's not a problem, we will use it to deal with their symptoms, but if you're using it, it might cover up symptoms that you need to know about. If using it chronically can increase their risk for developing cataracts younger, and it can definitely delay wound healing. So you got to be careful about using topical steroids. So let's talk about pressure. About 30% of the population are what we call steroid responders. That means if you put a topical steroid on their eye, their pressure goes up. And this can happen with topical steroids. It can happen with periocular steroids, like creams and ointments that you're applying to your lids that melt and leach into the eye. It can also happen with intravitreal injections. They can all increase the pressure. And the normal range of pressure in the eye is between 11 and 21. That's a normal bell curve distribution. And steroid responders, their pressure can go up by 10 to 20 millimeters. And it can start to do that within a couple of days. And if someone, has a pressure in the 30s for a few days, that can result in vision loss. So you got to be very careful. Dexamethasone and prednisolone are the biggest problem. So if you're putting them on a topical steroid, make sure you're monitoring their pressure in some form or another.
We watch it. We get them to come in before we prescribe it. They have to promise to come in daily, the first couple days, and get an idea. Yeah,
usually we're having them do it within a short period of time just to make sure. All right, so talking about glaucoma and red eyes, let's talk about acute angle closure glaucoma. So this is another hot red eye that can be vision threatening. So what's the mechanism of glaucoma and the flow of the eye? So aqueous fluid is produced in the ciliary body, and then that flows beside the lens and between the lens and the iris, and it flows into the anterior chamber, and then it flows into the trabecular meshwork, which is located in the angle that's adjacent to the back of the cornea and the front of the iris. And that's a normal flow of the aqueous fluid in the eye. In acute angle closure, what happens is that trabecular meshwork is blocked, and the blockage of that prevents the fluid from draining out. And so this is a plumbing issue. Fluid's pumped in, has nowhere to go, and so the pressure goes up, and it goes up quickly, and that increased pressure will damage the optic nerve and permanently have loss of those nerve fibers and vision and sight. So the symptoms they're coming in with moderate to severe pain and definitely blurred vision. The blurred vision is because the pressure is so high, it's causing swelling in the cornea. It's pushing fluid into that cornea because it's trying to go somewhere, and that it will induce the blurred vision and discomfort. These patients, they will often say that critical findings, you're looking at closed or narrow angle. So if you have a slit lamp or some way to look, you can see that that's closed. When you're measuring the pressure, you're going to find that the pressure is going to be high, likely over 40. You're going to see the cornea is very swollen and cloudy, and likewise the vision's going to be down. You're going to see a fixed and mid-dilated pupil, but in most cases, the cornea is going to be so swollen, you're not going to be able to see the pupil very well. It's going to be hard to see it. And they're going to have a lot of conjunctival injection in this eye.
I've only had one of these patients, and they're in such pain that they have to be driven because they're vomiting in the car, and it is one of the famous ones in life that cause severe pain. Most of the angle closures are a bit more chronic and mild, so they're a little bit more subtle. And then the other one you have to remember, you can have, first 2 weeks of COVID, I had a young 30-year-old yoga instructor said, "Oh, sometimes when I do downward dog, one eye feels funny or something's a bit strange." So you have to also remember Posner-Schlossen syndrome as well. That's an urgency.
So measuring the pressure is a lot easier than it used to be, and a lot of the clinics, if you're working through an emergency clinic or even the resource centers or medical clinics, a lot of them very well might have a tonometer that you can use. We've got the Tono pen, we've got an eye care tonometer. These are super easy to learn. You can learn how to use these in like 2 minutes. Anyone can do it, and they can give you a great pressure reading, and you don't need to use anesthetic with them. So great options out there so the learning curve doesn't have to be high to get a pressure reading. So the treatment that we're looking for with acute angle closure, the first thing that we're going to be doing is basically any and all glaucoma medications that we have. We're going to be putting them in the eye topically every 15 minutes for the first hour. You can put beta blockers in, alpha agonists, prostaglandins, carbonic anhydrous inhibitors. You're going to put them all, whatever you've got, as much as you can for the first hour. See if that lowers the pressure. If it's not responsive, then you might have to give them systemic CAIs. And then we're looking at immediate referral to ophthalmology on call. Sometimes there might need surgery to get it lowered. All right, foreign bodies. So this is your stereotypical patient. He works at an auto body shop, and he's called and he said, yeah, I got a piece of metal in my eye, and he comes in and he has a red eye. So he comes in, you can see the foreign body from a mile away on the cornea. The stereotypical guy, you can also see a bunch of other scars because he had multiple of these before, and he's a regular customer of removing these. But so you'll see the classic infiltrate underneath from the inflammatory response, and then you may see the foreign body. Take a look at the injection on the conjunctiva here. You have a sectoral injection just on that one area of the conjunctiva, pointing to that area. So, again, a clue of what the problem is, and that that this is not infectious at this point. So symptoms are coming in. Foreign body sensation, it kind of makes sense. Some of them, people may have pain. Everyone has a different tolerance of pain. Tearing, photophobia from the inflammation of the conjunctiva. They'll have a sectoral conjunctival injection, and obviously they could have some type of history going on. So on that, other questions, sometimes they'll say, well, were you wearing safety goggles? And I don't often ask that anymore because I don't feel it's really that valid of a point necessarily, because some of these foreign bodies, you can just get a flake of rust or of iron that just blows into the eye or falls into the eye if they're working under a vehicle or something like that. Doesn't come at a high rate of speed, but just lands in the tear layer, and then because the cornea is kind of soft, any burrs on that will just latch on and just kind of sit on the cornea superficially. And then if it sits there for a period of time, you're going to get that white inflammatory response underneath, and then probably within 24 hours it'll actually start to rust, and so you'll see a little bit of rust on that around that foreign body. So you do want to rule out the risk for a penetrating eye injury. So you do want to ask them, what was happening when this happened? Like, were you grinding? Was someone around you grinding? Is there any possibility of this being something that flew in your eye at a high rate of speed? And try to rule that out. And if you can rule that out, then you're a little bit more at ease. If it was coming at a high rate of speed, then you need to be mindful that this could be a penetrating eye injury. So how do we remove this? Superficially, you just basically get to flick these off in some manner. I do not use a cotton swab because they're just too wispy and not really fine enough. It'll work, but you're going to create a nice corneal abrasion as well, which is okay. That's going to heal up, but it's just not as neat as you could do. I personally use a pair of forceps, not to grab the foreign body, but I use a pair of forceps closed, and I just kind of tease and flick it out and try to get it onto the edge of the forceps. And when you're doing that, you're going to cause some damage to the epithelium. Don't worry about that. That's going to heal up. 24 hours, no big deal. You're getting the problem out. and it's going to heal up and it's going to be great. You could also use, if you have a needle, side of a needle, you're going to be good. Anything with an adjacent motion, flicking it out, you're at very low risk of penetrating the cornea. The Bowman's membrane in the cornea is very, very, very tough. If you are pushing something, indenting in with a pair of forceps or even a needle, you're not going to penetrate that. And even we have algae brushes or burrs. If you're going at a flat angle, you get it. If you're going straight on with your needle, you can penetrate it. But it's going to be very, very difficult to penetrate the cornea if you're brushing that out. So when there may be some rust when you remove it. There may be some rust left in there. Now, what I will try to do is I'll try to get the rust out, because the rust, it can be a little bit toxic or irritating to the epithelial tissues, so it will delay healing of the epithelium. And in some cases, if there's enough rust in there, then the epithelium won't ever quite heal, and it'll have trouble healing, and then you have to go in and dig more of that rust out. But I find a lot of the rust will leach out on its own with time, so leaving a little bit isn't the end of the world.
All optometrists have algae brushes, and it's just a little kind of a spud that spins, and you just touch it and the rust flies out.
Yeah, you can just basically grind that out.
So if you do have an algae brush, that's beautiful. The other thing is, you didn't ask about vegetation. So if it could be they were mowing the lawn or in the yard, you might want to just think about, am I also going to protect fungal?
Absolutely, yeah. So depending on what the origin of it is, so then the treatment that you're going to do, you're going to put a topical antibiotic on it, mostly just for coverage to prevent, particularly if it's some vegetative source of foreign body. But these are going to heal up. Once you get the foreign body out, the patient's going to be happy. That cornea is going to heal up within 24 hours. One thing that's good to remember, the healing of the cornea heals the epithelium heals very, very quickly. I think it's about 48 hours that the entire epithelial layer, there's about 3-4 layers of cells of epithelium completely replaced. When they do PRK surgery, they're making about a 6 millimeter abrasion on the surface of the cornea, and that heals up within a couple of days. So these abrasions heal really, really quickly. So talking about penetrating, if you're concerned about a penetrating eye injury, you want to think about Seidel sign. So this is basically, penetrating injuries can be a little bit, I don't know, masquerading is the right word, but you can be a little bit misleading, because you might see an abrasion on the surface of the cornea, but you see nothing at all. And it might have gone right through the cornea, right through the iris, right through the lens, right into the posterior chamber, and you might not see any sign of it. And this looks like the wound is sealed up completely, and it looks like, well, this just looks like superficial, and you can't really tell. Sometimes you'll see an entry point in the iris or the in the lens, but it could also go through the sclera. So if you're suspecting or at risk, you do a Seidel sign. So basically what you do, you take a fluorescein strip and you get a lot of fluid on there, and then basically you dab that right on top of the suspected area. So I've got a little video here. We'll see if this plays. And this is what you're going to see. You're going to call it, it's kind of like a waterfall effect, where you can see this lesion, and you can see there's aqueous fluid that's seeping out of that wound and causing that fluorescein pattern to kind of waterfall down. So that's the Seidel sign, if you're seeing that. I did have one patient who, he was walking in the bush, clearing some bush, and he got hit in the eye with a branch and thought he had a corneal abrasion, came in and looked, and actually the branch penetrated through the cornea and hit his iris, and then came right out and sealed up the wound. He had a Seidel sign, but we had to get him for some more urgent treatment. But he had no clue that this was a penetrating injury. So, all right, so if the foreign body, you don't see one on the cornea, but they have a foreign body sensation, oftentimes they're going to say, it feels like something's underneath my upper lid. So what are we going to do? We want to flip over the lid, take a look. So how do you do lid eversion? So we've got another video here. Basically, you get to take a cotton swab, grab the lashes, and usually I'll grab some of the edge of the lid margin, get a firm grip. You're going to pinch that, pull that out, and kind of flip that lid over, and then you can hold it up either your finger or the cotton swab, and you can take a look underneath the upper lid. There's a tarsal plate, a hard plate in the upper lid, and that's what you're kind of flipping over. Some people definitely have easier eyes to flip than others, and sometimes you got to get a real good grasp and flip that over. And one of the tricky things, the more wet and weepy, their eyes, their lids get very slippery. So sometimes it can be hard to grab that. So if you do see, flip over the lid. I put fluorescein in before I do this because often fluorescein will highlight an abrasion or where the foreign body is located, and then you can, here I will take a cotton swab and dab that out. But if you don't see anything and you don't have any magnification to take a closer look, because sometimes it could be just a really fine particle. I've seen little asbestos hairs, or I've seen, bug wings, something really, really tiny that's there. What you can do is take a cotton swab, moisten it with some saline solution, and then just give it a swab on the upper lid and see if it comes out. This is one case where it's nice not to put any anesthetic in unless you absolutely have to, because if you get the foreign body out, they're going to know immediately. They'll say, it's gone. And then you can know, hey, I've dealt with that issue. Oh yeah, if you are thinking, do you want to talk about that?
No, it's just that you may have an ultrasound near you or in your office, but any suspicion at all of foreign object, we have other equipment in our office, but ultrasound would make the most sense for you.
Yeah, they say ultrasound or X-ray if you have the ability to get a dilated fundus exam with photos to look for a penetrating injury. Those are the things. That's the way you're looking for that. All right, so let's say we just got an abrasion, so a scratch on the surface of the cornea. So here we want to differentiate abrasion versus ulcer. So take a look in the top right photo there. We've got a very large abrasion. Remember back for that infiltrative, that ulcer that we had in the very first slide. And this is a large staining epithelium. But what you won't see on this, and you don't see it very well here, is that white inflammatory response from the stroma. You won't have that. You'll just see this really defined abrasion that stains brightly with fluorescein. You can also have other staining patterns in the cornea. On the bottom left, that's what we call inferior punctate staining. So that's very common in dry eye. That can also be common with perhaps a chemical injury where there's a higher concentration that pools in the lower tear lake. The bottom right is a chemical irritation where the entire cornea has this punctate keratitis. These little pinpoint, punctate keratitis is little pinpoint abrasions on the surface of the cornea. So top right, abrasions, there are lots of reasons they can happen. Parents with small children, those little babies have really quick and sharp fingernails. They can get paper cuts are pretty common. Mascara wands, all sorts of things can got that. So what are you going to do for that? The treatment for these is basically you're going to put an antibiotic on it in some way to give you some type of coverage.
If you came in the 1990s, we would pressure patch you.
Oh my.
And then early 2000s to 2005, we would do a Band-Aid contact lens. And we've gone kind of simple the last 15 years. No pressure patching and no Band-Aid contact lens.
So most of these abrasions, like I said, the cornea is going to heal up within 24, 48 hours. Like that one in the top right, if I saw that one this afternoon, I see him tomorrow, I expect that's almost completely healed up.
Unless they're an eye rubber.
Yeah. So what you're doing for this period of time, you're mostly doing pain management and being able to tolerate. The old theory was pressure patch was not to help it heal faster, but it was to prevent them from blinking, so they didn't have that discomfort of blinking. And the pressure patches, they're just horrible to do and to experience. Basically, you're trying to force the lid shut so they can't open the lid is the purpose of the pressure patch. So then we started using bandage contact lens, which I still will use that if they're in a lot of pain. You can put that on and we'll put antibiotics on and they'll be a lot more comfortable with that. But if they can tolerate the discomfort, just oral pain management, maximal oral pain management, and even not prescription pain management, I think this can be easily managed with over-the-counter pain management, and that goes a long ways. One thing we will, if you have an abrasion, particularly a fingernail, paper cut, something that's like a really sharp abrasion, you want to think about recurrent corneal erosion. So this is where that epithelium fails to adhere to the basement membrane. So I described to the patient the cells grow over the surface of the abrasion, they heal up, but they don't grow roots down into the stroma to hold it in place. And they're just sitting there over the stroma very loosely. And what happens at night when you're sleeping, your lid has a little bit of friction between those epithelial cells. In the morning, your lid opens and it rips off some of those epithelial cells again. And what they commonly will say, oh, I woke up in a really sharp pain in the morning and a lot of discomfort. Oftentimes by the time they get to the clinic, it's actually healed up. You don't see anything, or you might see a negative staining pattern like this. You put some fluorescein in and it'll look like like the fluorescein pattern dissipates really quickly in that area. And that will be the symptoms of it. So what you need to do is you need to somehow prevent those cells from being ripped off every single morning. So the thing I'd use for this is a Muro 128, which is an over-the-counter hypertonic salt solution. Well, it comes in an ointment and drop. I usually use an ointment. I say put an ointment in every evening. And how long you do that? The question is, there's no test that we can do to know when those epithelial cells are healed. So
when the memory of the pain is gone, you'll stop.
So I often will say, you need to put this ointment in for like 3 months and do it every night for 3 months. And then after 3 months, maybe do it every other night for a couple of months until you forget. And if it comes back, then come back and see me or start doing this longer. There are some treatments that can be done if it is recurrent over and over and this isn't working. So
I don't use the Muro 128. I use a lubricating gel instead, but the Muro 128 is just as good. The other thing is sometimes patients will say, the pain in my eye woke me up. Sometimes when they're dreaming, their eye is moving and the cells from the cornea stick onto the back of the lid. And so they could be totally in sleep without opening their eyes and wake up from the pain first before they open their eyes.
All right. There's very few things that ophthalmologists or surgeons are worried about with the eyes. They're very comfortable with most stuff with the eyes, but one of the things that worries them is endophthalmitis. So endophthalmitis is an infection internally in the eye, and very serious, and it is vision threatening, and good chance you might have enucleation. So someone comes in with endophthalmitis, usually they're going to have pain and significantly rapid reduced vision. The critical signs is you're going to see hypopia. And I'll go back to that other slide. You see on the lower this arrow, it's always helpful when they come in with arrows, and you see this white at the bottom on that slide. What that is, that's not on the cornea, that's in the anterior chamber. And that's basically, there's so much inflammation and infection inside the eye, is that the body's sending white blood cells that are accumulating, and then gravity pulls them and they're settling in the lower portion of the anterior chamber. That's hypopia, and that's a sign of a serious eye problem, likely endophthalmitis, that you want to get someone to look at. They have a significant anterior and posterior chamber reaction. They're going to have some type of history of surgery in the last few weeks. So if you have a patient that's had cataract surgery or some type of surgery in the last few weeks, or if they've had a penetrating eye injury and you're saying, this is referral to the surgeon, pretty well anyone on call, but preferably the surgeon that did the surgery, they're going to need oral antibiotics and likely surgical intervention. Okay, uveitis, anterior uveitis. So this one will come in often, and this one can often easily be missed because it comes in as this chronic red eye. They present with pain or discomfort, but it's not I wouldn't say it's pain, but it's more like an ache if they're going to have it. And they're going to have ciliary injection. That's that ciliary flush, or that injection right around the limbus. They're going to be sensitive to light typically. They're going to be more of a watery eye. It's going to typically be monocular red eye, and it's going to be a red eye that might be unresponsive to treatment. So if you're treating something that you thought was a bacterial conjunctivitis or some type of conjunctivitis, and it's not getting better, sometimes think uveitis. Critical findings, you need to take a look with a slit lamp to look for cells and flare. The technique that you use for that is basically you want to put the slit lamp at the highest magnification it has. You're going to dim the room lights to completely dark, basically turn off all the lights in the room, because you need to dark adapt in order to see the white blood cells in the anterior chamber. You're going to put the brightest beam on the slit lamp, and kind of a narrow beam, but not a slit, but a narrow, kind of, they call it a pipette a beam of light, and you're going to shine it at about a 45-degree angle. And you're going to look through the slit lamp, and you're going to get it in focus where the anterior chamber would be, and you're going to just sit there and look in the microscope. And you might be looking there for like 30 seconds. It feels like a long time. And you're just sitting there. And normally the anterior chamber, when you shine a light through it, it's completely black. You don't see a light beam going through it. You don't see anything. But if you have an iritis, you're going to see these pinpoint white little cells that are typically floating up or down. They don't usually go sideways. They're going to go up and down. And they're going to see them just float by. You don't go looking for them. Just sit in one spot. They'll come to you, and you'll see them drift by. And that's the sign of, if you see that, that's, you have an iritis or uveitis. The other thing that you can see is flare. And what flare is, that's like, think of sunbeam through a window where you see dust with the sunbeam pattern. You're going to see the pattern of your light beam in that anterior chamber. Etiology of iritis and anterior uveitis, it can sometimes be tricky to find it out. Very often it's idiopathic. We have no idea. It just shows up and happens for no particular reason. But it is associated with autoimmune disorders. So these are the ones that you might be tested on, that you want to be thinking about if you have a patient that the optometrist has sent to you saying, hey, let's do we should investigate this further. We're thinking of, any of the autoimmune disorders, and also infectious systemic conditions that you're looking for. But it is looking for a needle in the haystack. So sometimes you may not know. So often our philosophy is, generally in eye care, is the first iritis, you get one free. So the first incidence of an iritis, we don't worry too much about it. We treat it and manage it. As long as it's monocular and it responds to treatment, then we say, it happened. Hopefully it doesn't happen again. But if it happens again, or if it's binocular, or if it doesn't respond to treatment, then that indicates we need to do some type of systemic workup. And usually we're referring back to the family physician to try to do that, do a review of systems, looking for some cause, usually autoimmune disorder. I will often tell patients, I'll say, hey, if I see an iritis, I will often mention, hey, is there anything that your family that you've had a weird symptom that you've asked your doctor about and they haven't had an answer for and haven't found it? And sometimes I say, oh yeah, my back's sore or something weird like that. And I said, well, it might be related. Maybe it might take us help give them some additional information. So tell your doctor about that. Treatment for this, we're going to put them on a cycloplegic when you have an iritis or it is inflaming the ciliary body. So that's going to cause pain and discomfort. So cycloplegic is going to freeze that iris so they don't have that discomfort. And then we put them on maximum topical steroids. We hit them with the strongest steroid we have as much as we can to try to get that inflammation as quickly as possible. Once we have it quietened down, we monitor them every 1 to 2 days until we know it's quietened down. Once it's quietened down and gone away, then we can slowly taper off those steroids. If you take them off too quickly, it's going to rebound right away.
And it's usually tapering over months.
Yeah, we're tapering over months, yeah. Weeks or months. So the pearl here, if you got a chronic red eye with ciliary flush like this, that's monocular, kind of think, oh, is there a possibility this might be an iritis? Because they happen, they're pretty common. All right, this one, giant cell arteritis or arteritic ischemic optic neuropathy or temporal arteritis. Got lots of different names for this condition. This is not a red eye. So this will not present as a red eye, but I put it in here because it is a vision-threatening condition that you might get presented into your clinic. The patient's going to present with a sudden, painless vision loss. So their eye's not going to be painful and their vision's going to be reduced significantly. And they may have a headache, they may have jaw claudication, they might have scalp tenderness. So the critical findings is you're looking for an afferent pupillary defect, and because it's swelling of the optic nerve. And if you have some ability to look in the eye with the ophthalmoscope or a slit lamp or imaging, you're going to see a swollen optic nerve. And if you're seeing that with an afferent defect with reduced vision and pain, think that it might be this, because this is vision threatening very quickly. Vision loss might be in the range of count fingers. Like we're talking profound vision loss all of a sudden. So the treatment for this is to diagnose it. You're looking at you get an ESR, getting a temporal artery biopsy, but those both take time. And if you're waiting for the results of those before you initiate treatment, likely this person is going to be blind in that eye, and it's probably spread to the other eye, and they might have bilateral blindness before you get the results back. So if you suspect this is the issue, they need to go on immediate systemic steroids, treat it. You're often treating this before you have a definitive diagnosis on it. All right, so those are the super serious eye problems. So we'll calm down, we'll bring the tone down a little bit to some less severe stuff that you might be running into. So let's talk about sectoral injection. So I talked about red eyes that come in where you have just a section of the conjunctiva that's red. And these are ones that are not corneal involved. So they're just involving the conjunctiva. So the ones we're thinking about, subconjunctival hemorrhage, pterygium pinguicula, episcleritis, scleritis. But let's talk about the anatomy of the eyeball, so of the conjunctiva. So the top layer is the conjunctiva. Conjunctiva is a clear, loose mucous membrane that has blood vessels in it. Underneath the conjunctiva is the episclera. It's another clear, slightly less loose tissue that has blood vessels in it. But the episclera, the vessels, or it's kind of segmented, like it has different sections in it. So if there's one section that's inflamed, you'll see only one section. So when you see sectoral injection, it could be a clue that the episclera is involved. Sclera is the white structural support to the eyeball underneath. It also has vessels in it.
The conjunctiva also extends to cover the inside of the eyelids, and the area that it stops around the cornea is called the limbus.
All right, so let's talk about subconjunctival hemorrhage. So this is it'll often present as a kind of a sectoral injection, but it's not an injection. You can pretty well see it's not an injection. You can tell it's a hemorrhage. So this is basically a broken conjunctival vessel and starts to bleed underneath the conjunctiva. And that tissue is very loose, so that blood spreads to a large area, and so you'll get this large hemorrhage on the right-hand side. Patients are very concerned about this because it looks really, really bad, and so they will often present with this problem that they have in the eyes. Now, the etiology of these, again, oftentimes idiopathic. It just happens out of the blue for no particular reason. But you got to rule out the other things that could cause it. Obviously, trauma. So you've got hit in the eye. Good chance that that's what caused it. Got poked your eye. Even if you're rubbing your eye really hard, that could cause this. If someone's on a blood thinner, anything that thins the blood could put you at more risk for developing.
Like Advil, aspirin.
Well, aspirin, yeah.
Sometimes people take a lot.
So any blood thinners can put you at more risk for developing that. So that's a question I will ask if they're on that. Anything that can increase the blood pressure to the head. So coughing, vomiting, sneezing, lifting heavy weights, bending over for a prolonged period of time, all those type of things can cause you to develop a subconjunctival hemorrhage. So if you kind of go through all that list of say, okay, have you had any of these and nothing, then you go, oh, yeah, it just happened. It's basically a bruise. It's a broken blood vessel. So
they may say the next day it got worse. What happens is they're sitting or standing during the day, the gravity pulls the blood underneath the lower lid so they don't see it when they go to bed, but they might have slept on their side or their back and the blood has moved. So when they wake up in the morning, it's very dramatic. And it's kind of like any other contusion. I tell patients day 5 to 10 tends to be that green-yellow, and then day 10 to 14 tends to be that yellow-brown color. So sometimes we give them cool compresses or we give them artificial tears because that lid has to kind of travel over that bump of blood, and they don't really like that feeling.
Yeah, the treatment is, I tell them, it's the same thing as a bruise, which is just time. You just need time. There's nothing you can do to clear this up any faster. Vasoconstrictors or anti-redness drops, I tell them not to use those because those aren't going to help. You just need some time and make up a good story. And I will tell them if this happens every once in a while, not a big deal. But if it starts happening on a recurrent basis, and I tell them a recurrent to me is every month, or if it starts happening in both eyes, then I will say, hey, make an appointment with your family doctor just to ask them, hey, is there a reason why I might be bruising or my blood's not clotting as quickly as possible. I don't know. I will ask them if they're bruised easily, things like that. As far as if they are on a blood thinner, I will tell them do not stop your blood thinner because you're on that for a very specific reason, I'm assuming. So sectoral injection here. So here we have pterygium and pingueculi. So the left-hand side, bottom left is a pinguecula. The top is a pterygium. Fun words to say, not fun to spell. So pinguecula, this is an inflammation or tissue buildup on the conjunctiva. So this is a issue with the conjunctiva, and the cause is from chronic dryness or UV exposure to the elements. And basically, I will describe it to patients almost like building up a callus. That tissue is irritated, and the body says this tissue is irritated. We want to protect the eyeball, so we're going to grow some more tissue in that spot and have some more blood vessels. So you'll have this raised nodule. The yellowish appearance is kind of fatty tissue in the conjunctiva. They'll have more blood vessels, so it will look more red. And when it gets more irritated, it'll get really inflamed and even more red. And it will definitely be more nasal and temporal in the areas that are exposed. Treatment for this is lubricating drops. It can help quieten it down, maybe. But you need to use a lot of them for a long period of time because this didn't start overnight. This started a long time ago, and if it's going to go away, it's going to take a long time for it to go away. But I don't think you can get rid of them with the lubricating drop. You can just reduce how much it's inflamed. If someone's spending a lot of time outdoors, wear UV protection. Topical mild steroids can quieten down an inflamed pinguecula and make it feel a little bit more better. I have an asterisk there for the reasons I talked before about be cautious of using topical steroids. And if it's really bad and cosmetically annoying or physically bothering the patient when they blink, surgical excision is an option.
The scar, though, is not always pretty because it's an indentation, so it's not the perfect solution. Also, you want to avoid the over-the-counter Visine, Clear Eyes, any vasoconstrictor because the rebound hyperemia, it's going to look way worse if they use any of those drops.
Absolutely. Okay, so pterygium, this is a similar type of thing, but that lesion is actually growing onto the surface of the cornea. Not all pinguecula will turn into a pterygium, but some will. But it seems it's a related situation. So the conjunctiva is growing onto the cornea. Again, same cause of this. This one can affect the vision in two ways. One, like here, you see it's just on the fringe of the iris. So this one probably isn't affecting the vision because it's blocking the patient's vision. However, these pull and stretch the cornea and will increase the amount of astigmatism or the asymmetry of the symmetry of the cornea and warp the cornea to really distort the vision. So someone might have reduced vision that we can't correct with a refraction because of this pterygium. But if it grows right over the surface of the pupil, then it affects the vision. But I rarely see those. So treatments, again, same treatments. But if you want to get rid of this, you need surgical excision.
The reason he doesn't see that is because Manitoba doesn't grow this naturally. If this has occurred, this means that this person has spent some years under 18 in a location closer to the equator than Manitoba.
Yeah.
Yeah. So that's why once they move here, it's never going to grow over the pupil here.
Okay, so here's one that kind of looks like a pterygium or not a pterygium, looks like a pinguecula. And so Episcleritis and scleritis. So Episcleritis is an inflammation in the episclera, and you're going to get this sectoral injection. And you're going to see these more, quite commonly, and sometimes you'll mistake them as maybe a pinguecula, or sometimes you might mistake them as a viral conjunctivitis. So Episcleritis, what is that? It's a sectoral injection or inflammation of the episclera vessels. Patient's going to present with some discomfort. They're going to have injection of those superficial vessels in the episclera and probably in the conjunctiva as well. And they typically occur in younger patients. So you want to differentiate this from a scleritis, which is an inflammation of the blood vessels of the sclera, because a scleritis is serious. Episcleritis, not so much. The scleritis is a connective tissue disease associated with autoimmune disorders. The patient's going to present with a lot of deep pain, kind of a boring, really deep, uncomfortable pain. It's affecting the deep vessels of the sclera. And so the question is, how can you differentiate these two? So there's a couple ways you can do it. One is you can just take a cotton swab and see if you can move what you can move. And if you could put a cotton swab on there and you try to move those vessels, if they're moving, they're either conjunctival or episcleral vessels. If you can't move them, then they're scleral vessels. So that's one way you can differentiate it. Other way you can use is using phenylephrine. So phenylephrine in different concentrations can help differentiate between different levels, because the higher the concentration, the more the phenylephrine will penetrate into the tissues and blanch the blood vessels or constrict the blood vessels. So a 2.5% phenylephrine won't penetrate down to the sclera, so it's not going to tell you anything there. And it won't penetrate down into the episclera, but it will penetrate into the conjunctiva. So if you put 2.5% phenylephrine, you'll blanch the conjunctiva, but not the episcleral vessels. If you put 10% in, it will blanch the conjunctiva, episcleral, but not the scleral vessels. So that's another way you can help differentiate it if the pain and
you don't need them
discomfort is not a clue.
Then.
Yeah, fair enough. Treatments. Episcleritis, if it's really mild, you can treat it with artificial tears, lubricating drops. You just need some time, and it takes some time. Like, it's weeks for this to resolve, but it will eventually goes away. So you do need to tell the patient that, otherwise they will book an appointment with you in a week saying, why hasn't this gone away? Or they'll book an appointment. Actually, what they'll do is they'll book an appointment with somebody else in a week because this hasn't gone away. If it's moderate or severe, oral NSAIDs can be of benefit, or you can use a mild topical steroid, which I find but again, asterisk there for a reason. Be careful with the topical steroids because of the risks that they pose. Scleritis treatment, this is a referral to ophthalmology. They need oral NSAIDs, they need likely oral steroids. They may be putting on immunomodulators, and they might need surgical intervention for this. So watch for that scleritis. All right. Let's talk about conjunctivitis. So this is an issue just affecting the conjunctiva. The big three, and these are not affecting the cornea. So this is just affecting the conjunctiva. We've got allergic, viral, and bacterial. Allergic conjunctivitis, they're going to present, oftentimes it's bilateral. I mean, if it's an allergy, why is it only affecting one eye? That'd be weird. But the differential that you're looking is, it can often be dry eye if they have an itchy bilateral red eye. The treatment for this is basically topical mast cell stabilizers, and to help treat the allergic conjunctivitis. There's a very particular type of allergic conjunctivitis. You want to talk about
the general one, you're listening for watery and itchy. Those are the two words you're writing down and listening. Vernal's a little bit different. Usually the parents come in, because it tends to be in elementary school kids, saying, my kid has this nervous blinking habit. I don't like it. Over the 30 years, the 4 weeks of the year that I find this, it has shifted a bit. So September has kind of moved to early October. December is still December, kind of a week or two before Christmas. And then April is now, I've been finding, turns to middle March. And that fire smoke season tends to be in August. These kids' innate immune system just seems to be trigger happy, so you often see an association with asthma. And you can easily see this. So if you lower the lids, you can see these papillae with that cobblestone effect, with that light reflecting that way.
And it's even more so, you can see it more so with fluorescein. Right?
Oh, I'm too lazy. It just seems too obvious. I don't know. Basically, this is totally self-limiting, so I give the parents 3 options. I say, we can do nothing. 2 is, if it's becoming a nervous habit, we could do cool compresses. You could do artificial tears, keep them in the fridge, and replace the eye rubbing with the cool compresses and the cool artificial tears. But mast cell stabilizers work really awesome. So Hatinol is now over the counter in the US, not in Canada. Reprieve is also pretty easy to find. I get them to put it in the morning, and then the second dose I let them choose, is it easier after school so they're not doing the blinking in the evening, or is it easier before bed because they're running around doing too many other activities. And they often ask how long. I said, you know, you'll probably start forgetting as soon as that blinking habit goes away.
All right, viral conjunctivitis. So viral conjunctivitis is probably, they tell us in textbooks, and I think it's real. It's probably the number one cause of conjunctivitis that you're having that's coming in. The patient's coming in with a red eye. They think they have pink eye or something, but they're going to present with this diffuse, mild red eye. It's going to be, you know, a watery, weepy discharge. They're going to have some chemosis of the conjunctiva. It might actually be really quite swollen. And, you know, I put in cornea is not involved. There are some cases where it is involved, but most of the time it's not involved. It starts in one eye. It can definitely spread to the other eye. And it's lasting like 2 to 3 weeks. And they're going to might find their eyes are burning and just feels just really weepy and uncomfortable. So your common culprits for this are adenovirus. We know COVID will definitely cause this. You know, measles, mumps, chickenpox, any viral type of things can give you issues. So treatment for viral conjunctivitis, we basically just need some time. And you're using artificial tears, cold compresses. You're managing the symptoms. And be careful not to touch and spread this because you are contagious for about 10 to 12 days from the onset. You want to be careful about what you're sharing with other family members and what you're touching. Sometimes you can use steroids if there are infiltrates involved. So one type of viral conjunctivitis that does have involvement in the cornea is EKC, so epidemic keratoconjunctivitis. So this is the one that optometrists, you know, flip out about because this is the one where you have to do the COVID style of wipe down of your office. We're more used to that, but before COVID, you know, when you had to do what did that patient touch? Where did they sit? What pen did they use? You know, you need to, basically this virus is sitting on any surface and anyone else that's touching that, they can easily spread this to themselves. So these do not respond to any viral, well, generally not speaking to any viral drops, and they're very contagious. And they can involve the cornea. So in the bottom right, this is a really extreme case. They can get corneal infiltrates that will sit there for months, years, and they'll sit there and they can sometimes affect the vision. So they can be very frustrating to a patient. Even after the conjunctivitis is cleared up, those infiltrates are just sitting there. Sometimes we'll use steroids to try to clear those. And there are some optometrists, I've never actually done this, that have betadine in their office where they dilute it down, and actually they suspect this. They'll, you know, do a flush of the eye with betadine to try to kill any active virus that's there. Any other ones with virus? Okay. Bacterial conjunctivitis. They're presenting with this mucousy pink or mucousy green, yellow discharge. You could have a foreign body sensation. Not if the cornea is not involved, so they're not photophobic. The lid's usually not involved unless it's a keratitis or an infection. Vision is pretty good. Cornea is, you know, all that type of stuff. So treatment. One thing you want to just when you're asking them about the discharge, they'll often say it's crusty in the morning, but it can be just crusty in the morning because the dried tears, and it may not actually be a mucus discharge. So ask if it's like what the discharge is through the day, if it's kind of mucousy or pussy, or if it's more kind of watery. Treatment, these are self-limiting. Your body's immune system is really good at fighting these off. 5 to 7 days. If you put them on a topical antibiotic, they're resolving in a couple days sooner. But we do know that the prolonged antibiotic drops, if you are using them too long or too much, it can irritate and damage the tissue. I talked about that medicamentosa issue. Favorite topical antibiotics. These are mine. This is just my personal opinion of what I often use. I will use Tobrex often. Bacterial conjunctivitis responds pretty well to that. Kids, I'll often use Polytrim. It's a really mild drop antibiotic works really quite well, and particularly in really young ages, down to 3 months. Fluoroquinolones, I don't hesitate in using them. There is talk about resistance, but personally, I don't feel the resistance effect is being driven by the eye care drops necessarily. But if you have a patient with a bacterial conjunctivitis that is a contact lens wearer, I'll put them on a fluoroquinolone. I don't know. Do you have what? You might have a different opinion.
Okay.
Yeah. One particular type of one is, if you have a chronic, it seems like a bacterial conjunctivitis, it's mucousy, stringy discharge that this patient has, and it's just not responding to topical treatments. It's going on for weeks. It's recurring, happening often. Pull down the lower lid, you see papillae here. Think about chlamydia. It does happen, and they will need they'll need oral antibiotics to deal with this. So if you get a chronic, don't forget about these ones. All right, moving a little bit away from the eyeball, let's talk about the lids and the redness that you can get from the lids. So we've got kind of 4 main categories: lid edema, inflammation of the lids, redness that is just from the position of the lid, and then actual lid infections. So lid edema, I put that in here because sometimes you can have just a swollen lid that's not infected from a serious eye problem. So, I talked about infectious keratitis, a corneal ulcer, herpetic keratitis. Any of those serious vision-threatening conditions you can present with lid edema. So you might see these really swollen lids, and you might be focused on the lid being a problem, but it might be a problem that's going on deeper. So be aware of those ones. So let's talk about inflammation to the eyelids that can cause redness. So there's a condition called blepharitis or Meibomianitis. It's a chicken and egg. We don't know which comes first. They're associated and related. So on the left-hand side, you're going to see inflammation along the lid margin, and you're going to see little scales and debris along the base of the lid lashes. So here's upper lid. You can see these little white spots here. These are the openings of the Meibomian gland. So these are blocked, inflamed Meibomian glands, and those are causing some issues with dryness and irritation. Here you can see these little flakes and debris at the base of the lid of the lashes. This is blepharitis. So these are debris and flakes that you can see there. So what is blepharitis? Blepharitis, I tell patients, this is a chronic mild lid infection from the natural flora or bacteria that lives on the skin. I will tell them there's bacteria that lives on our skin. It's supposed to be there. It needs to be there. And for whatever reason, there's some of the situation in your eye, either the temperature, pH, chemistry, is just perfect for that bacteria, and they just love you, and they are reproducing at a great rate, more than you need, and they're producing a lot of waste products and poop that collects along the lid margins, and that's what you see, those little flakes of debris, and almost looks like dandruffs at the base of the lid margins. And those waste products are very inflammatory. They will cause a red lid margin. They'll fall into your tears and cause the conjunctiva to be red and irritated, and just make your eyes burning and itching and irritated and just unhappy. You see on the slide of the injection, you'll see how that injection increases to the fornix, and particularly inferior. Blepharitis that'll be common here because gravity pulls everything down. There's a particular type of blepharitis that involves an organism called Demodex, and this is actually a mite. So Demodex mite is an organism that lives in the follicles of your lashes, and under high medication, this is what it looks like. He's a friendly little fella, and he lives there, and he causes all sorts of havoc and inflammation and irritation, and he is hard to get rid of. So 45% of blepharitis out there, when you see those flakes on there, 45% of them is due to Demodex. It increases with age. So if you are 70 years old, there is a 100% chance that you have a Demodex infestation of the lashes. So these ones can be dealt with. So how are you dealing with blepharitis is you need to clean these off. So you need a soapy-like solution that doesn't sting your eyes to get rid of the waste products, and in some cases kill the organism that's dealing with it. So we use lid wipes. I've got Cystane lid wipes, Clean. These are a couple of good ones that are out there. In the past, we used to recommend baby shampoo, but we do not recommend that anymore because not for 30 years. We have not recommended baby shampoo because it actually causes dry eye and inflammation, and it doesn't really solve the problem. And these are super easy and cheap to get. They're way easier to use anyway. So you're using these once or twice a day, cleaning around your lids and lashes. If you have Demodex and you want to get rid of that, you need some type of active ingredient to kill the Demodex organism. Oftentimes they will include some amount of tea tree oil to kill it, and they'll have to do the lid wipes usually monthly. It take a month or 2 months to get rid of it, and sometimes they'll have to just be on them long term. We will often use topical antibiotics and steroids to quieten the inflammation and maybe quieten down really severe inflammation, but the topical antibiotics won't kill Demodex. I think you had a point about tea tree oil.
Oh, don't tell your patients to use tea tree oil, because if they put any of it in their eye, they're going to get a lot of pain and a severe red eye.
Yeah, like the ones that they're using for their skin, they're too concentrated for the eyes. Lid position. These might look like a red eye, but so if you have a top right, this is ectropion. The lid is floppy and it's lost the tension of the lid, and so the lid's flopping open, and you can see the palpebral conjunctiva, and from a distance it looks like they have a red eye, but basically it's just exposed. Entropion, the lid is turned in and the lashes are rubbing on the cornea or the conjunctiva, causing abrasions and irritation and a red eye. The treatment for these both is surgical intervention, but in the meantime, you're going to put them on lubrication, maybe tape the lid in some form or fashion so it doesn't give as much issue. Infections to the lid. So we'll refer to these as hordeolums or styes. The glands that are infected when this occurs, there's kind of 3 main glands that will typically be affected. The glands of mole and Zeiss are more anterior of the lid, and these are sweat glands, and if those are infected, that's going to be called a anterior hordeolum.
Or
external hordeolum, yeah. And if it's a Meibomian gland, which are a little bit deeper, those are infected, it's going to be called an internal hordeolum or a stye. Basically, you get a red swollen lid. They might have discharge, usually not. The conjunctiva is going to look pretty clear and white, and it's going to be very tender to the touch. So how are we going to deal with these? These are self-limiting. Again, the body's really good at fighting off these. 5 to 10 days. Usually patients show up on day 2, and I will tell them this is going to get worse for 2 more days, and then it will start to get better. That you want to do lid hygiene to keep their lids clean. Hot compresses is a great treatment. You want heat and a bunch of it. So heat to the lids for 5 to 10 minutes, because it takes a while for that heat to penetrate into the lid, and you want to do that like 3-4 times a day. So a washcloth cools off too quickly, so you want something like there's those magic bags, or there's all sorts of gel packs that you heat up in the microwave like for 30 seconds. They hold the heat for 5 to 10 minutes. You just obviously don't want to burn yourself. Put that on, and that repeated heat can help quieten this down. Topical antibiotics are really not effective in any way. If you're going to treat it with an oral antibiotic, which can help. And that I often reserve those for chronic or severe ones. And this will often develop into a chalazion. Yeah, so chalazion basically it's no longer infected, but the gland becomes clogged with all the mucus and debris in it, and you have this hard, firm, non-tender nodule in the lid. And so again, heat can be helpful. Excision can help. Some optometrists, we are using radio frequency and intense pulse light. So if you're not familiar with these came to optometry from the aesthetics and dermatology world. Radio frequency is heat, and that's used for skin tightening and fine lines and wrinkles. But we will use the same technology to heat the Meibomian glands to treat eyelid disease, but it can help resolve this. Intense pulse light, dermatology uses that to treat rosacea and photofacials, fine blood vessels, and remove sun spots. We will use that to treat the inflammation, and both of those can be used to maybe treat chalazion and not have to go for excision. Want to rule out when you have a stye or a hordeolum. preseptal cellulitis. So preseptal cellulitis, this is one of my golf buddies. He sent me a photo. Hey, Michael, I think I have a problem with my eyeball. And so he's going to present with a warm, red, swollen upper lid. And it's going to be a more diffuse tenderness because a preseptal cellulitis is not an infection of a gland, but it's an infection of the entire lid. And so it's going to be more diffuse. They're going to have trouble opening their eye and deal with that. So the treatment for preseptal is oral antibiotics. Sometimes they'll put them on IV antibiotics, but you want to rule out orbital cellulitis. So orbital cellulitis is a situation when that infection is not just in the anterior portion of the lid, but it's spread to behind the septum and into the orbit. So they have an active infection in the orbit of the eye.
Or the brain.
Which can lead to the brain. So severe problem and very concerning. So symptoms are going to be similar to a preseptal cellulitis, but they're going to be more. There's going to be more pain, more red, more swollen. There's possibly systemic symptoms like fever, headaches. They might have double vision because if it's spread to the orbit, it's affecting now the extraocular muscles and the movement of those. And so the patient might have trouble moving that eye, so they might have double vision. Or if you try to physically move the eye for them, they might have trouble. Or if you...
I think you should still do your broad age.
Yeah.
And with both of them, they may say pain in both, but you can definitely tell once you start moving as orbital cellulitis, there's excess pain.
Yeah. These ones, orbital cellulitis, that's referral ophthalmology. They need a CT scan. They need cultures. We're worried about meningitis. They need IV antibiotics for these. Okay, dry eye. Dry eye is you're gonna see this a lot, but you may not realize it. So eyes presenting as this chronic red eye, you might mistake it for an iritis, but dry eye is extremely common and it is a disease. So it's chronic. Symptoms they'll get, they might have a foreign body sensation, but reflex tearing is a very common symptom with dry eye disease, and here's the reason why. The anatomy of our eyeball, we have a layer of tears that sits on the surface of the cornea, and it sits there, and it takes about 8 seconds for that to evaporate off, and that protects the surface of the cornea from the outside elements. If someone has dry eye disease, those tears are evaporating off too quickly. The problem with most people with dry eye is not that they don't have enough tears, but it's the quality of the tears. So the quality of their tear is very, very poor, and so they evaporate off too quickly. When they evaporate off, it exposes the delicate pain and touch fibers in the cornea to the air. The eye thinks something's in it, and so the response of the eye is to produce a watery tear to flush that, watery tear to flush that out. And so people will walk in their dog, defrost, air conditioning blowing by, their eyes will often water. That's almost always dry eye. It can be associated with blepharitis. We talked about meibomian gland dysfunction, and you'll see this classic on this bottom left hand, that inferior punctate keratite or staining of the cornea. That's like always dry eye. If you see that, put staining in and you see that pattern on the lower portion of the cornea only, dry eye. Treatment, we got lots of things to treat dry eye now. Depending on how much work and effort someone wants to go to, we can manage dry eye pretty well. Lubricating drops are a band-aid treatment, but you can use them preservative-free or best to prevent the tears from evaporating off. Heat or warm compresses, so again, we talk about something that holds heat for 5 to 10 minutes. What you're doing there is you're softening the meibomian glands to get those flowing better. So it takes some time to warm up those glands. So it takes 5 to 10 minutes of heat. Doing that once a day can be helpful. Omega-3s can reduce the inflammation. The other issue with the meibomian glands is they're inflamed and not producing a very good meibome. So omega-3 can reduce that inflammation, but you need the right type and the right amount. You need the re-esterified omega-3s, which is the more expensive form of it. Otherwise, this the regular run-of-the-mill brand. It doesn't absorb into your system to a therapeutic level. Topical steroids we'll sometimes use on a short-term basis. Prescription drops like Restasis, Xiidra, and now we have Cequa. We're looking at cyclosporin.
Yeah, and the grams.
Yeah.
Cequa is 0.09%.
These can be effective to reduce the inflammation in the glands, to reduce the dry eye symptoms. Oral low-dose doxycycline can be beneficial to reduce some of the inflammation. And I mentioned about radiofrequency and intense pulse light, that we now have options there to treat these. So lots of things in our arsenal to go with.
We're going to do a little bit about ophthalmia neonatorum, otherwise known as neonatal conjunctivitis. So what you can see here, newborns, doesn't matter if through C-section or vaginal birth in North America, they all get about 0.5% erythromycin ointment, and they apply it underneath the lower lid right near after birth. So the two big things that we're trying to think about, the two bacterial ones you're going to be concerned about are the gonorrhea and the chlamydia. So the other infections like toxoplasmosis, which comes from cat feces exposure, cytomegalovirus, rubella, HIV, those will tend to present inside the eye, so they will not necessarily cause the red eye. So if you're getting a newborn 6 hours to 1 day with a red eye, you're going to first think chemical. So this is not an allergy to the erythromycin, it's irritation. And if you don't really have to do anything, but if the parents want something done, you can irrigate the eyes with saline to try and make their baby feel better and make nicer photos. But if it's only in one eye, you could also consider it could be a corneal abrasion. Those newborn fingernails are quite rough and ragged as the skin comes off. And if you want to see if that's the case, you put a little bit of fluorescein in the eye and set your ophthalmoscope to the blue light and just shine that in. If it is just a corneal abrasion, you could continue or add erythromycin ointment, but you don't want to do that if it was a chemical reaction. So day 2 to 7, you're thinking bacterial, and most likely at that day it'll be the Neisseria gonorrhea. So this one, it can lead to blindness, and it has a lot of symptoms. This one is treated with the one dose, either intramuscular IV antibiotic, and you can do topical supportive antibiotic as well. So you're thinking gram-negative, and with that, you get a lot of neutrophils. So the discharge is extremely purulent, very pyogenic reaction here. This is not subtle. This is the least subtle of any of the conditions you're going to have. If you're getting it presented kind of day 7 to 21, you might be thinking other type of bacterial causes. So the chlamydia is a little bit more watery at the discharge. And if you can get the lids flipped, you will see the papillary reaction on the lid, so those little bumps underneath the lids. It could be strep or Staph aureus, but that's less likely. So we'll just assume it's chlamydia. And that one works really well with the macrolides orally. Once you get past week 2, or start like day 15 plus, you start thinking virus, and the one you want to keep in mind is your HSV2. So you'll ask birth history, and this one may not have too much discharge because it's virus, and you can have some corneal staining and ulcerations. You may see vesicles, you may not, but that one works really well with the oral and the topical antivirals. Once you get a bit older to preschoolers, especially after age 1, parents are going to be really pushing for antibiotics for their kids to get back into daycare. So we have kind of a keen awareness that over-prescribing and inappropriate prescribing leads to antibiotic resistance and can actually harm the patients. Bacterial, viral, allergic, vernal, they're all self-limiting. So like Michael said, talking about what they're doing in the house to make sure that they're reducing the transmission, lots of laundry. And if you're going to use on the little kids antibiotics, I stay away from the fluoroquinolones and the fusidic acids. And I tend to, if I can't talk them into artificial tears, the polytrim is where I go because you get both a broad coverage. And then if it is allergy, it works really well with the mast cell stabilizers.
If you're looking for resources on the eyes, in addition to UpToDate, so UpToDate has a lot of good information for you. But if you're looking for a physical hard copy, version, Will's Eye Manual is a book you can buy it on Amazon. I think it's like $70-$80. But this is tell you everything you need to know about any eye disease and how to diagnose it and how to manage it. This is a staple in every optometry and ophthalmology rotation. So if you're looking for a resource that you can call on, then this is a great one to look up. What else in the area of eye care not related to red eye? We're going to talk a little bit of things. I did talk a little bit about intense pulse light and radio frequency. If you hear of optometry doing that, it's usually for dry eye. So that's something that's going on. Myopia management, myopia or nearsightedness, we now have options in optometry and ophthalmology to slow down the progression of nearsightedness. So nearsightedness is a global issue, and it's increasing worldwide. And in the past, there wasn't anything we can do to slow it down, but now there are options in glasses, contact lenses, and topical low-dose atropine that can all slow down the progression of myopia by about 50%. So the reason why we mention this is if you have kids coming in and they have fixed and dilated pupils, and you're going, wow, what's going on? You might want to ask them if they're on a low-dose atropine.
Or even sensitivity to light.
Yeah. So the treatment that we put them on, the normal concentration of atropine for dilating pupils is 1%. The concentration for treating myopia is 0.05%. It's compounded, and this is actually off-label use of atropine, but it does work, and use it every evening. And these kids can be on this, they're years. Like, we're looking through all of their preteens and early teens that they're on this, and it is very effective in slowing down the progression of myopia. So if you see kids of that, now if you see a kid with a monocular non-function, dilated pupil, they might be on topical atropine to treat amblyopia. So that is a treatment to treat amblyopia where you're actually purposely blurring the vision up close for that child. So if a patient's on that, child's on that, that could be another reason if you're seeing weird pupils in kids. Any other comments on those? Or that's good. Flashes and floaters are extremely common. We have, I probably see one patient a day that comes in with either presenting with new floaters or flashes. Fortunately, most of the time it's a vitreous detachment, but about 10% of the time it's a retinal tear that we'll identify. So if you have someone with flashes and floaters, optometrists, we see this all day long, and you can get them in, and if we see a tear, we're setting them up to ophthalmology, and most of the time it's not, and it's a happy visit for the patient. So